Hello and welcome. You found the Social Work Podcast. My name's Jonathan Singer, and I'll be your host as we explore all things social work. Today's Social Work Podcast looks at the issue of non-suicidal self-injury, or NSSI. NSSI is a hot topic among clinicians and psychotherapists today, but this wasn't always the case. 20 or 30 years ago, the only folks talking about NSSI, and actually back then it was self-injurious behavior or deliberate self-harm, were therapists who worked with borderline personality disorder. And this was, in part, because BPD was the only DSM diagnosis, and actually still is the only DSM diagnosis, that includes self-injury as a symptom. In fact, self-harm became a red flag for borderline personality disorder. If you had a client who engaged in self-harm, you'd start with the assumption that he or she had borderline personality disorder. But times have changed. While cutting and burning and other forms of self-injury are more common among people with psychiatric diagnoses, the presence of non-suicidal self-injury no longer implies an access to diagnosis, or any diagnosis at all for that matter. A 2011 study by David Klonsky found that nearly 6% of adults in the USA reported a lifetime history of non-suicidal self-injury. For U.S. adults under the age of 30, it was 19%. And interestingly, a 2012 study by today's guest, Jennifer Muehlenkamp, and her colleagues found that the international prevalence of NSSI among adolescents was 18%, nearly the same as in U.S. adolescents. For reasons that aren't clear, NSSI has moved from being a symptom of a serious personality disorder to a coping mechanism used by nearly 1 in 5 adolescents. So, NSSI has become a hot topic in recent years, in part because it's showing up in the general population rather than just a small subgroup of psychiatric patients. Now, this change in who engages in NSSI has also renewed interest in the question of why people engage in NSSI. Are people who self-injure numb and trying to feel something? Or are they feeling too much, overwhelmed by their emotions, and they're cutting because they want to feel less? Is self-injury a pathway towards or a pathway away from suicide? In the late 1930s, Carl Menninger suggested that self-injurious behavior was a way to, quote, avert suicide. I remember this one teenager told me he would try everything to get suicidal thoughts out of his mind. And as a last resort, when nothing else helped, he'd cut himself, not to die, but to get rid of the ideation. And he said it worked every time. One non-lethal cut that would draw a small amount of blood, and the ideation would be gone, sometimes for up to a month. The thing that was so fascinating for me was that he only engaged in NSSI when he was overwhelmed by thoughts of killing himself. So Menninger's hypothesis fit this kid, but it doesn't seem to fit for everyone. In fact, research has suggested that youth who say they engage in NSSI and have thoughts of suicide are actually at higher risk of attempting suicide than youth who report suicidal ideation or NSSI alone. So, for the clinician who works with people who self-injure, understanding the purpose and the meaning of the self-injury, the risk posed by the self-injury, and how to best address it, these are all issues that need to be worked out. If all of this makes NSSI sound complicated, it's because it is. And that's one of the reasons why I spoke with Jennifer Muehlenkamp, associate professor at the University of Wisconsin, Eau Claire, and one of the world's leading experts in NSSI. In today's episode, Jennifer and I talked about the definition of NSSI, the intersection between suicidal and non-suicidal self-injury, some of the things clinicians should and should not do when working with clients who self-injure. And we ended our conversation with some speculation on the future of NSSI as a standalone psychiatric disorder in the DSM-5. We recorded this interview in April of 2012 at the American Association of Suicidology conference. I cornered her as she was waiting for an elevator in between conference sessions and asked her if she'd be willing to talk about NSSI for the podcast. Now, the thing is that we don't really know each other. We've seen each other at the conferences. Of course, I'm familiar with her research, but she's so good that without batting an eyelash or without any prep time, she agreed, and we had the conversation you're about to hear. And during our conversation, she never once mentioned that she was at the conference in part to receive one of the most prestigious awards in the field of suicidology, the Schneidman Award for Outstanding Contributions in Research in the field of suicidology by an early-stage investigator. There's a picture of her accepting that award on the Social Work Podcast website. And if that were not enough, she put together an outstanding list of scholarly books, peer-reviewed journal articles, and memoir about non-suicidal self-injury that you can find on the Social Work Podcast website. And the last thing that I'll say about NSSI is that my colleagues over at the Living Proof podcast published a wonderful episode on NSSI with one of Jennifer's colleagues, Janice Whitlock, the week after I returned from the Suicidology conference. If you're interested in it, you want to learn more, there are tons of resources, and I've put them on the Social Work Podcast website. So, without further ado, on to episode 73 of the Social Work Podcast, Non-Suicidal Self-Injury, an interview with Jennifer Muehlenkamp. Jennifer, thanks so much for being here and talking with us on the Social Work Podcast about non-suicidal self-injury. The first question is, what is non-suicidal self-injury?
Well, non-suicidal self-injury is a behavior, and the way we define it in the field right now is that it's the deliberate or the intentional destruction of body tissue without suicidal intent, and the behavior is not done for socially approved reasons, so that means things like tattooing and body piercing do not count as self-injury. And so self-injury, another key piece to it is that with it being bodily tissue damage means that the damage is immediate. So sometimes people will ask me, so is binge drinking and is disordered eating, are those examples of self-injury? And we consider those indirect forms of general self-harm, because non-suicidal self-injury is actually results in immediate tissue damage.
So like somebody burning themselves with a cigarette or cutting themselves with a knife?
Yes, exactly. And what we find is that cutting is one of the most common behaviors, particularly among adolescents, particularly among young adult females, whereas things such as intentional banging or punching objects in order to induce a bruise. Banging behavior is more common in males as well as the punching. And the banging might be taking one's, let's say, wrist and slamming it against the side of a table or slamming it against the side of a wall or something like that a few times in order to get a bruise to create some kind of sensation. I had one client who would not only cut himself, which is a little bit different for males, but not only cut himself, but when he get really upset is that he would take his fist and he would bang it on the corner of his desk at school. And he would do it probably 5 or 6 times till he said it felt numb and kind of tingly, and then he would be done.
So clearly that's self-injury and it's not suicidal. Like you can't kill yourself by, banging your fist against the side of a desk. Right. So clearly that's non-suicidal. But if you were working with somebody who came in and had cut marks on their arm, like how would you know that that's non-suicidal self-injury?
That's a really good question. One of the first things you really need to do, right, is ask people. Because we know that most adolescents and young adults, the people who engage in this behavior, will be upfront and say, no, I'm not trying to kill myself. They often engage in this behavior to cope with their distress. And it helps them cope with emotions. And some of the key emotions that they face are things like anger and anxiety. A lot of them will say that they engage in this behavior sometimes to punish themselves because they don't think they're worthy or they did something wrong. And so if you ask them in a gentle way, kind of around the line of, so tell me, what does self-injury do for you? Like, how does this behavior help you? Then you'll first break down some barriers and get someone to be more willing to talk to you about it, but then you'll also get to see it. And then you can just ask them, were you wanting to die from this? Did you want to kill yourself as a result of this behavior? And they'll often tell you no. The other thing is that we know that people who die from suicide or who make very lethal suicide attempts often do not do so through cutting, which I think a lot of people are very concerned about because cutting is potentially very damaging and you can have very severe wounds, but it's very hard and it's very rare to die from cutting. And so of those individuals who do engage in self-injury and very severe self-injury who do make a suicide attempt, oftentimes the attempt is through a different means or a different method than what the self-injury was. So the first step is really ask them about their intent and what the behavior does for them.
So really, if somebody comes in and I see that they've got cut marks on their arm, I could, of course, gently, right, with rapport and do all the sort of therapeutic things that we do, but eventually get around to saying, so I noticed that you have cut marks on your arm. What were you intending to do? Something like that, right? So, one of the things that I've heard about cutters, right, sort of this generic term for non-suicidal self-injury, kids who cut but don't want to die, is that they cut because the pain of the cutting is something that they can deal with, but the pain inside is something that they can't. So it's sort of like it transfers the pain. Is that right? I mean, is that, that's what I've heard on the street kind of thing from other therapists. But I guess my question is, why do people engage in NSSI?
What we're finding in the research, there's a lot of reasons why people engage in self-injury. And what you said and what you described is, I would say, somewhat accurate. So there are a lot of people, and what we know is that the emotional state right before an act of self-injury is often one of intolerable distress. And like we said, oftentimes very negative emotions, intense emotions sadness is not real common. Just a lot of people think, oh, they're so depressed and that's why they do it. What the research shows is it's more of the high tension, high arousal kind of negative emotions. So the anger, the anxiety, the frustration. And what we find is that the kids and the people who engage in this behavior just they find it very overwhelming. And so engaging in the behavior not only produces a little bit of relief, but it also kind of gives them an immediate solution. And I know to people who don't engage in the behavior, that can seem sort of bizarre, but we also know physiologically what happens when you get a wound is that not only do you have a release of endorphins in your body, which are feel-good chemicals, but we also get a release of cortisol, which helps us to focus our attention. So some people will also engage in the behavior because things seem so out of control, they don't know how to problem solve. Self-injury actually calms them down, and they can now focus and actually maybe then start to engage in more adaptive problem solving. So sometimes it is to externalize the pain. I had one client who would talk about how she would feel so numb inside that she would self-injure in order to feel pain, to remind herself that she is alive and she is a person. But a lot of the clients that I work with, it was really more along the lines of, let me kind of get rid of this negative emotion right away. So kind of that immediate gratification, so then I can move on, rather than kind of riding out the slower tide of emotions that we need to let dissipate.
Do you find that kids who start out cutting or doing some other sort of NSSI,
It's a hard term.
it is. Go on to become suicidal? Like, is there a trajectory? Because I know that's something that parents and sort of the general public is concerned about.
Sure. And what I can say is that it's good to be concerned. And if you're working with someone who's engaging in self-injury, to ask them periodically. And what you want to do is ask them about warning signs that you see if they start to feel more hopeless, pull away from people. So if you see basic suicide warning signs, be concerned. With that said, there's a large portion of adolescents who engage in this behavior who are never suicidal. We don't have great longitudinal studies. Of the cross-sectional studies we have, which means that you study kind of one group in time, and then you ask them, when did you start self-injuring? If you've attempted suicide, when did you attempt suicide? What we find is the age at which they engage in self-injury tends to be significantly younger than the age at which they make their first suicide attempt. So that would suggest that self-injury might lead into suicidal behavior if they get to a suicidal state. state. I know of one longitudinal study in college students, which I happen to be involved in, that we did find longitudinally over a 3-year period that of the college students who engaged in 20 or more acts of self-injury in their lifetime, that predicted over a 3-year time period who was likely to engage in either making a suicidal plan or attempting suicide. And so there is a predictive relationship there, but what we often see is that things get a lot worse for the individual. And anecdotally, so I'm still trying to find data for it, but one of the things I've heard clinically is that when self-injury doesn't work anymore for the individual, that's when I'd be most concerned, because that's their coping strategy. And if it's not working anymore, they're going to get to that ultimate desperation and become more suicidal.
So when you have somebody that engages in NSSI as a coping strategy, maybe the first step in problem solving, as you were describing earlier, what are some things to do with that client to help them to develop maybe better coping skills rather than self-injurious behavior? Or do you say self-injurious behavior is not really that bad if it helps them do what they need to do and move on?
Mm-hmm. I think you're raising a fundamental question that goes back to all kinds of dysfunctional behaviors, right? At what point do we really need to intervene? When is it a problem? And so on.
Sort of abstinence versus harm reduction.
Right. And I know there's some people in Australia who are really advocating a harm reduction model, which I find interesting. I'm kind of in the camp that suggests that self-injury is a pretty... I don't want to say, it's not really invasive, it can be, but it's a pretty extreme behavior for coping. And so generally what I recommend clinically is one of the first things you can do is not immediately ask the person to stop. It's really unsettling as a clinician, as a parent, as a friend to watch someone intentionally, right, cut themselves, burn themselves, do something very damaging. But what's really important is to first recognize that it is their coping strategy. So just like if you go home and what your coping strategy is to take a nice warm shower, right, or to kick back and watch Family Guy or whatever it might be, right? And suddenly you say, your therapist says, you can't watch Family Guy anymore, right? You can't take a warm shower. You're going to either stop therapy or things are not going to go well for you. So what you want to do is start gradually. And you can use some of the basic cognitive behavioral strategies to start to address, their thoughts that they might be having, to help them think about what other things could you do. Where I often start, to be honest, is to work on delaying. And so not means removal and not means restriction, but basically start with delay. Can you engage and try some of these other behaviors, coping strategies first? And, start with one, and if that doesn't work, then maybe you can self-injure. Then you extend that, right? So then do 2 or 3 things. And then if that doesn't work, you've got your self-injury. So you slowly kind of build the steps away from the self-injury and let them see that the other things do work if you give them time. Another strategy that I've used, and I can tell you about, I've used it with 2 clients pretty successfully, and there's one client that really comes to mind who had engaged in very, very severe self-injury for many years. And we were at the point where we were talking about, are you willing to get rid of your razor blades or not? And she said no. And so I respected that. But what we did is we took her razor blades and we put them inside basically a coping box is what we called it. And she had a box of things where she had pictures of her sisters, pictures of friends, notes that when she was doing good that she would write to herself to remind herself about what's good. So we put all those things in there. And then she also put the box in the back of her closet, which she told me was really messy. And so in order, when she would get really distressed and want to cut herself, she would have to go to the closet, dig to the back to pull the box out, and then she would encounter all those pictures, her positive coping statements and things like that would make her think about more of the long-term consequences of the self-injury, because she was committed to not engaging in the self-injury. And that really was a huge step for her and really worked well for her.
That's amazing. In terms of suicide prevention, I'm thinking of the what they did in England about making Tylenol only available in bubble packs.
Right.
If you have to pop each one out, it's very different than opening up a bottle. Like if you have to go to the back of a messy closet, dig out a box to get your razor blades, just probably that time delay was an important way to do some delaying, as you said.
Yeah, I think so. And I think another big part of it is that she was very connected to her family and friends and wanting to make a difference. And so I think if you can find that long-term goal that a client is really striving to and make it immediately salient to them, because a lot of times people who self-injure are so focused on the immediate distress that they put off their long-term goal for the immediate distress relief, that if you can bring that long-term goal to the immediate, you're also more likely to then trigger adaptive problem solving and kind of promote more of a delayed gratification, so to speak.
So non-suicidal self-injury is defined by being not suicidal, right? And is that something that people are talking about in terms of like the terminology, or how it sort of defines the behaviors by what it's not? And I guess a bigger question is there any move to make non-suicidal self-injury like its own disorder diagnosis, like anything like that? Well, like is anything coming down the pike?
Yes. In fact, if anyone's been sort of following the APA or the American Psychiatric Association's revision of the DSM-5, what you'll see, and it has been somewhat of a controversial discussion, is that they are proposing a non-suicidal self-injury disorder for DSM-5. And it is primarily based on the fact that this is a behavior distinct from suicide that could be its own risk factor for suicide, and that we see this behavior in many people who do not meet diagnostic criteria for borderline personality disorder, which is what the behavior has commonly been associated with. And in fact, the highest rates where you see this behavior in terms of a disorder is actually among individuals with bulimia nervosa. And so eating disorders have the highest rate of self-injury, as well as individuals who are suffering from post-traumatic stress disorder or PTSD, as well as some of the depression and the other anxiety disorders. So the behavior is definitely defined by what it's not, and that's a key debate that's out there in the field, as far as, because we know suicidal behavior often is associated with ambivalent intent, fluctuating intent. 1 minute you want to die, the next minute you don't. And there are some people who do describe that during their acts of self-injury, they might have a fleeting thought about suicide, but the behavior was not engaged in with the intent to die. So it adds a lot of ambiguity. And so I think that's where, as a clinician, it's really important to talk with your client and to even ask them at any point in your self-injury, did thoughts of suicide come up? And if they say yes, then that's a doorway to ask, well, how strong were they, right? So that you can kind of monitor for it without, I guess, negating the fact that the individual is saying, I'm not suicidal, right? But you can still do your assessment in that way. I think with the potential for the non-suicidal self-injury disorder to come to fruition is that clinicians will be able to hopefully get some more precise training on it, to start to look at the behavior as a behavioral problem, because a lot of the treatments that we have out there work with behavioral methods to reduce the behavior. And once we have an identified disorder and it's not wrapped up in another stigmatized disorder, we can, I think, be more effective in both our treatment and our prevention.
So are there any other things that clinicians should think about or know about, be aware of with regards to working with folks who engage in NSSI?
I think there's probably about a couple other things that come to mind that I've been asked before by clinicians. One is that a lot of times clinicians ask me, well, if I'm disgusted by the behavior, or I find the behavior hard to deal with or just hard to understand, what should I do? Because sometimes it's hard to hold back your visceral reaction to things. And I think the first thing to recognize is that those are common responses that people will have. And it's also the time where you want to do, kind of put on your clinical face, right? And do the best you can to internally monitor, recognize that that's your reaction. And then also recognize that individuals who are sharing this behavior detect those, kind of subtle reactions. And so they'll really pull back if they think you're scared or it's too much or you're disgusted by it. So one of the things we really recommend is that the way you ask about the behavior, after you ask about it, inquire a little bit more from their perspective, saying, oh, that surprises me about you, if you're really shocked by it, and then ask them to explain more about the behavior for them. So to find a gentle way to enter into it. The other thing that I'm almost always asked is, should I look at the wounds? And I will tell you, there's some debate in the field about whether or not you should. I think a majority of people say do not look at the wounds. And there's a couple reasons for that. One is, well, first of all, if it's a place that they're injuring that's inappropriate, you have have to not look at it, right? It's inappropriate.
Right,
You don't
like
want to.
I'm cutting on the inside of my leg. Right.
Right.
Yeah.
So don't look at it. The other part is that if it's, forearms, calves, and things like that are easy, is that for some people, they believe if you look at it, you might inadvertently reinforce the behavior, because for some people, they use it as a signal to others to say, I'm in a lot of distress, help me out. And so as a therapist, if that's the way you communicate about the self-injury, you might actually increase the self-injury, because that's how they'll tell you about their distress instead of learning their emotion words. And the other thing is that if you're worried about the severity, I just ask my clients to report. So I'll ask my client who says, I cut myself the other day and I think it was pretty bad. And so I'm not a medical provider, and they know that up front. And I'll say, I'm not a medical provider, but can you tell me, how badly did it bleed? Was there a big gap? Did it actually stop bleeding and you could see tissue underneath? I had one client who cut so deeply to the point where it actually stopped bleeding. And so she was in the next day, fortunately, and I said, you need to go to the, emergency department to get stitches. I'm pretty sure, And so just asking things about that, or if they burn themselves, are you getting blisters? Is it oozing? Like that kind of stuff, just to get a basic assessment and then know if you have to refer them to a medical provider.
Such great information. Jennifer, thank you so much for taking the time to talking with us today about non-suicidal self-injury. I really appreciate it.
Yeah, well, thank you. I really enjoyed talking to you.
I'm Jonathan Singer, and thanks for being with me today for another episode of the Social Work Podcast. If you missed an episode or have suggestions for future episodes, please visit socialworkpodcast.com. If you'd like to support the podcast, please visit our online store at cafepress.com/swpodcast. To all the social workers out there, keep up the good work. We'll see you next time at the Social Work Podcast.